our colon, which is normal, in colon also, what we always see in a normal colon, the crypts are tall and they are perpendicular. This is the muscularis mucosae. So if you draw a line, they will be perfectly perpendicular. And normally the crypts reach and they pinch over the muscularis mucosae. So there is no space in between the tip of the deepest part of the crypts and the muscularis mucosae. And this distance in between, this is even if you see here. But sometimes if we look from the top of this rack, the crypts, the test tubes will look like this. So whenever the intestinal biopsy is not properly oriented and it is transversely cut, it will appear just like this. It is the case what this picture was given to you to interpret. So here also you can see, so if I draw and try to see if they are evenly spaced or not, the space in between is even and there is not much inflammation. So if I go back, I have drawn a line in between the mucosa to divide into two segments. The upper part was the lumen and this is the lower part. Our volunteer already has discussed, Dr. Harish, that there is some inflammation. So now I will draw your attention and you will see that the inflammatory cells, what we can see, they are on the luminal part only and they are not present into the deeper part of the mucosa. So see, it is always present because all our antigen is present in the lumen. So there will be always some lymphocytes and plasma cells what can be seen here into the upper half of the mucosa. But there will be rarely some inflammatory cells will be present into the deeper part. So something to call as inflamed mucosa, we need to see more density of inflammatory cells and there should be redistribution of the inflammatory cells into the lower part or lower half of the mucosa also, what we are not seeing here. So architecturally it is normal. So first, if you see now onwards any intestinal biopsy, try to see from where it has been taken and then you have to look at the architecture and decide if the architecture is normal or not and if the mucosa is inflamed or not. So these two basic things you have to do, and if you are accustomed to the chrysanthemum flowers in the garden, so see how nicely they are evenly they are oriented. It just mimics the intestinal biopsy mimics a bunch of chrysanthemum flowers. So this is actually a normal. And this I was mentioning, this was the picture given to you. So the inflammatory cell, if I draw a line, some inflammatory cell is present into the upper half or luminal half. They are not redistributed into the other part. But see this biopsy, this is another case not given to you. The number of the inflammatory cells are more and it is redistributed both into the upper half as well as they have been redistributed into the lower half. So now this biopsy is inflamed. We are not talking about it is acutely inflamed or chronic inflammation. We are just saying the architecture is maintained here, but the biopsy is inflamed. So the interpretation is that first case, the biopsy is normal. Now distorted architecture, as I was talking about, so it will be something like this. So what is distortion? Distortion means, see, there will be a disorganized appearance. Somewhere the test tubes are not there. And if you look from the top, there will be somewhere the crypts or the test tubes are lost. And in other areas, the shape will be changing. There will be some back-to-back arrangement, what we see during the branching. So if I tell you or ask you if this biopsy is normal, colonic biopsy, all of you can tell the architecture is not normal. Is that clear? See, they are back-to-back arranged. That means this is a sign of branching. These are branching crypts. If I cut this transversely, they will appear as this. There will be a facet in between two branching crypts. And at places you can see we saw nice distribution with even spaces in between. Here in between there is a patch where you cannot see any crypts. This is a vertical branching, this is a transverse branching, and now you are seeing the crypts are becoming shorter. I told you normally the crypts are tall and they pinches over the muscularis mucosae. However, here you are seeing a space has been created between the muscularis mucosae and crypts. So this is not normal. And also our other rule was to draw a line and to see if the density of inflammation is more. So it is more than the normal what we have seen, and it has been redistributed into the lower half also. So it is inflamed and the architecture is abnormal. And we'll see when architecture is abnormal, what to interpret. So these are just different forms of architectural distortion. you can see vertical branching, you can see crypt branching like this. There can be areas of crypt loss, and sometimes, this is not very common, you will see metaplasia of the intestinal epithelium to other type of mature epithelium, like this is an example of pyloric metaplasia. So with that, we'll come to the case number 2. We have seen what is architecturally normal and abnormal, which is what is inflamed mucosa, and we'll come to the case number 2, and I will ask Dr. Tinku if she is there to take up the case.
Yes, sir. Section study shows fragment of colonic mucosa with focal areas of erosion. But then lamina propria shows dense inflammatory infiltrate predominantly consisting of neutrophils, then lymphocytes, plasma cells. Seen filled, dilated and congested capillaries can also be seen. Architecture is preserved in this fragment.
Okay, then I will give you 2 leading questions, because I asked you or I showed you these are the 2 most important points. One is architecture, and second you have to decide if the mucosa is inflamed or it is normal. So what would be your precise answers? Architecture?
Architecture.
You said something, just repeat that.
Mild distortion of architecture.
You think so? Okay, then we'll see is the mucosa is inflamed or it is normal. Apply our rule. If I draw a line somewhere here,
It appears normal.
it appears normal. Okay,
Yes.
now let me chip in, and I will tell you, these are the actually crypts. This is a tall crypt which has been cut in different planes, and you can see it is fragmented like this. But look at the spaces in between of each crypt, that is again not distorted. We are not seeing a patch where you cannot see any crypt. There is no branching, vertical or transverse branching, what you can see. And if I apply the other rule, I can still see there is some redistribution of the inflammatory cells, and focally it may be, this area it may be normal, but in other areas there is mild redistribution and mild increase in the density of the inflammatory cell. So I will tell, architecturally possibly it is normal, but the mucosa is mildly inflamed. Then we have to go to high power and try to see which type of inflammatory cells we are seeing. You have talked about lymphocytes, plasma cells, any other type of cells you can see in this picture?
You can appreciate intraepithelial neutrophils.
Okay, so you think these are the neutrophils, correct?
Yes. Yes.
So if you see neutrophils, what does that mean?
There is active inflammation.
Very nice. So we are seeing polymorphs. The polymorphs are there in the lamina propria, and polymorphs are there which are infiltrating the epithelium. So it is very important to recognize that whenever the polymorphs infiltrate the epithelium, we take that as a sign of activity or acute inflammation. Okay? So in this case, as the architecture is maintained, architecture distortion is a sign of chronicity. What I showed in the previous case, if you see there is distortion of architecture, you will take it as a feature of chronicity. That means there is chronic inflammation. However, in this case, the architecture is normal, but you are seeing epithelial injury by polymorphs. That is a sign of active or acute inflammation. So if you see a case like this, you will sign out it as it is a case of acute colitis or active colitis. Is that clear?
Yes.
Okay. So what can be the different forms of activity you can see? One, we have shown you that polymorphs can infiltrate the epithelium, either the surface epithelium or crypts, that we call as cryptitis. On the other hand, you can find some crypts which are dilated like this, it may be ruptured, and you can see accumulation of many polymorphs inside the lumen of the crypt, that is called crypt abscess. And there are some other forms where you can see surface erosion or surface ulceration like this. So you have to know when to call something as denudation and when to call something as ulceration or erosion. So if there is ulceration or erosion, there will be always some reaction. Reaction means in the form of acute inflammatory exudate, or there can be some inflammatory granulation tissue at the base. If you see there is discontinuity but there is no exudate or granulation tissue, you will call it as a denudation. Okay, that should be very clear. And if there is ulceration, you will see erythema and ulcers like this if you look at the endoscopy picture or see the gross specimens. So these are the features of activity. Now with that, we'll go to the case number 3. So we have seen what is chronicity in colonic biopsy, what is activity. Now we'll see, this is a ileocecal biopsy. I did not mention you the site, but it is quite clear. And in the form, it was written, query it is tuberculosis or query it is Crohn's disease. So whenever you will get a ileocecal biopsy from the gastroenterologist, this is the most common differential diagnosis they ask for. So I'll ask someone to volunteer, Dr. Pooja, if you are there. Dr. Pooja?
Yes, sir.
So you can take up this case. So this is a ileocecal biopsy I have already told. So I will give you some leading questions. So we have already discussed any biopsy, we have to look at the architecture and
Yes.
if the mucosa is inflamed. So tell us.
So in this we see fragments of ileocecal biopsy with the mild erosion or denudation of the mucosa, and there is architecturally the crypts are distorted and their crypt loss is also seen, and in the mucosa I could appreciate the test tube arrangement of the crypts are lost with little basal plasmacytosis. The crypts are not resting directly on the muscularis mucosae. So there is lamina propria shows increased inflammatory infiltrate. And on higher power, I could appreciate mainly lymphoplasmacytes and eosinophils.
Okay, that will come up later. So you have said the architecture is distorted. I am
Yes.
correct? And then you said the mucosa is inflamed.
Yes,
So
sir.
if you see this biopsy under microscope in your exam or get in a routine reporting, so what would be your interpretation? You have already noted the signs or the findings. So what will be your interpretation at bottom line of the report?
There is colitis.
Architecture
with the-
distortion means we have discussed it is acute or
Chronic.
this is a chronic. So this is chronic ileitis, and I will correct you. I told you this is ileocecal biopsy, but in this particular field, we are seeing two ileal mucosa. So whatever I am seeing, I will comment on that. So I will say this is, I can see this is a feature of chronicity. So this is chronic ileitis, and the mucosas are inflamed. That's why we are calling it ileitis. So in this power, we can say that only. So what in addition you have said there are the type of the inflammatory cells. You have seen many eosinophils. I agree with you, and you have seen the basal plasmacytosis. So what do you understand by basal plasmacytosis? Can you describe that?
Yes, sir. Usually the crypts, they are directly resting on the muscularis mucosae, but in
That is
this we
normal.
can-
That is
Yes.
normal. Yes.
That's normal. But in this, there is clear space between the crypts and the muscularis mucosae with inflammatory cells.
So I think it is clear to everyone. I have drawn that. So this zone is called basal zone. First thing. And then you have to go into high power and see if this basal zone is occupied by plasma cells or not. So then
Yes.
only you will call it basal plasmacytosis. So where you see basal plasmacytosis? Any idea?
In IBD, usually
In IBD you can see. But I told you this is ileocecal biopsy. You are correct. You are correct. I appreciate that. But this is ileocecal biopsy. So is there any clue? Because why I am repeating the same thing?
Crohn's.
No, I'll tell you. Then we can apply that formula if we see basal plasmacytosis in our colonic biopsies. So that is a important clue for the morphologist to identify if it is IBD type of colitis or not. But always please remember that some amount of basal plasmacytosis can always be physiologically seen in the ileocecal junction.
Okay.
And you have already talked about the eosinophils. In the ileocecal junction, eosinophils are normally, it is more, okay? Because there is a stasis, physiological stasis, the content, okay? The food antigens, the infection goes on there. So that's why eosinophil is always more in that place. So there are two sites in the intestine where eosinophils are more. One is the distal 2 centimeter in children of the esophagus, and one is ileocecal junction. There, if it is not too high, we keep a very high threshold to call something as mucosal eosinophilia. Okay. So before interpreting, so we have already interpreted this is a chronic ileitis, but before interpreting the basal plasmacytosis and eosinophilia as a feature of IBD or not, I should have a very high threshold. So in this case, I don't think we can interpret that. This is the high powered. This is the basal zone, what she already described. And this is the small focus of plasma cells or plasmacytosis in the basal zone. You can call it basal plasmacytosis, but I always think if it is very focal, it is physiological. And these are the eosinophils, what we can see physiologically also, we can see. And what else you can see here in these pictures? These pictures are also given to you. Anything in addition?
No, sir, I couldn't.
Okay, so architecture is one thing, but in the
Yes.
small bowel, as a part of the architectural interpretation, what we look for, crypt to villus ratio. That you know, crypt to villus ratio we always have to see. May it be duodenum or ileum. So if I draw a line between this is the shoulder of the biopsy, you can see the ileal villi are slightly flattened or shorter, but ILs are not increased. So this type of shorter villi and increased ILs you can also see in many infections in the ileum, like you can see in Crohn's disease and sometimes in tuberculosis also. So the intestinal response are same for all type of infections. We have to look at the context, and I appreciate you said I did not give any history. You have to look at the clinical detail and radiological findings to correlate everything, and then you have to reach to a diagnosis. But here, as a part of the architectural distortion, the villi are slightly flattened or shortened. Okay?
Yes.
And what is this? You can see in this area.
Yes, sir, some multinucleated
Giant cells.
giant cells were
Giant
there.
cells.
So what do you understand by that?
Granulo. But there are
you
no
know-
histiocytes as such. So
Nee, these
can
are all
you just-
histiocytes. These are histiocytes which have conglomerated together and formed these giant cells. But if you look very closely, the nuclei is not transformed. Okay, these are actually mucin granuloma giant cells formed due to the rupture of the crypts. These are called mucin granulomas. So I had put this picture to show you, because whenever you see some small granulomas in the mucosa, and you all know small granulomas can be seen in Crohn's disease also. But always try to see if it is a mucin granuloma or if it is a well-formed granuloma formed by the transformed histiocytes. Okay, epithelioid histiocytes, there or not. So in this case, this is a mucin granuloma. So what I already told you, in this case, I will keep my threshold very high. As I am not seeing a large granuloma like tuberculosis or not a convincing small granulomas in the mucosa, I can see there is architectural distortion, there is some shortening of the crypts, increased inflammation and focal basal plasmacytosis. I will not say if it is Crohn's or tuberculosis, because the features can be very overlapping. Okay, this I have already told you. So these type of features you can see both in Crohn's as well as tuberculosis.
Yes, sir.
So this is the mucin granuloma. See, these are nice histiocytes, round nuclei, but they have these are conglomerated histiocytes to form those mucin granulomas. If you do AB pass, you can see some mucin within the cytoplasm also. And here, in addition, what we can see, there is some form of activity. Can you see that?
Yes.
So we said this is a chronic ileitis. Now, which terminology we should say in the interpretation? So we are
Active,
seeing chronicity as well as activity. So what we'll call it?
acute on chronic.
Acute and chronic, but we as a
Chronic active.
the format is like that. We call it chronic active.
Chronic active.
Either chronic active colitis or ileitis. This is ileal biopsy. So the interpretation should be this is chronic active ileitis, and we cannot actually differentiate if it is tuberculosis or Crohn's disease. So we should know our limitations, and please remember, whatever ileocecal biopsies we get, 30 to 40% of the biopsies remain unclassified like this. We cannot always differentiate because these are superficial mucosal biopsies. Okay. So I was showing you histology of chronic active colitis. That means we'll be having chronicity, features of chronicity as well as features of activity. And if I now talk about the differential diagnosis, the first differential diagnosis where we can see the mixture of both activity and chronicity, that is IBD. Very important, you have to remember. And if you are staying in India or Southeast Asia, you have to remember tuberculosis. So you should not forget whenever you are seeing any chronic active ileitis or colitis, so you should remember that these two differential diagnoses, IBD and tuberculosis. However, if there is any persistent inflammation in immunocompromised patients, there can be also chronicity can be there, or activity also can be there. So persistent chronic infectious disease can also lead to this type of findings. We'll see some of the differential diagnosis later, and there can be other differentials also where you can see chronicity as well as activity. That means features of chronicity and features of activity are not disease specific. Is that clear? Okay. So with that, we'll go to the case 4. Case 4, Dr. Shitish or Dr. Kirti, anyone?
I'll take this.
Sir.
Yeah, please.
So H&E stain sections from the submitted biopsy shows a fragmented tissue bed with focally preserved colonic lining epithelium. Diffuse crypt loss is noted, along with dense mixed inflammatory infiltrate in the lamina propria, comprising of lymphocytes, plasma cells, neutrophils, and few eosinophils. Both cryptitis as well as crypt abscesses were seen. However, I did not notice any granulomas or giant cells. No parasites were seen.
Okay, so based on this picture, so what will be your interpretation in low power if you are looking at under microscope?
So there are features of chronicity in the form of crypt destruction. So there's diffuse crypt loss.
So this is chronic colitis, isn't
Chronic.
it? So
Yes.
if you look at my 2 questions, that will tell you the final answer. This is chronic colitis. Then we'll go to high power. Another thing I want to tell you in low power, see in this how many fragments you can identify?
6 fragments.
Almost 5-6 fragments.
Yes, sir.
So what I did not tell till now, you have to also see if the features of chronicity and the inflammatory features are evenly distributed across all the fragments or not. Because please remember, whenever a gastroenterologist or endoscopic take biopsies, they don't take all these biopsy fragments from one site. This is the protocol. So whenever you are trying to sample for diagnosis of IBD, you have to always sample from the ileocecal junction as well as rectum. In addition, as per the distribution of the lesion, you can take samples from other 4 sites of the colon. And usually the protocol is you have to take 2 biopsies from one site, but there are practical limitations, you all know. So we usually get in average 5 to 6 fragments whenever there is a question of chronicity. So as you have told, there is a diffuse finding. So do you agree with me? All the fragments are similarly inflamed and distorted?
Yes, sir.
So I will add another line. So in this power, if I have to interpret, so this is diffuse chronic colitis. So is that clear to all?
Yes.
So see that in low power. Now this is the high power. Any further comment you want to do?
So there's dense inflammation that is seen in the lamina.
Yeah, that you have already told.
Yes, sir. And
Whatever we have discussed, just try to recapitulate the things. We have already discussed those points. Okay, I will give you a lead. This is the muscularis mucosae.
yes, sir.
Now tell me what you have to see.
The basal plasmacytosis.
Yes. So, as the architecture is distorted, the crypts are short. So there is a zone in the basal. This is called basal zone, I told you. And you have to go into high power. And in this case, is almost all fragments are showing basal plasmacytosis.
Yes,
So
sir.
this is definitely important. So this is the high power. This is the muscularis mucosae. This is the deepest part of the crypt. This
Sir.
is, you can see, I think, this is basal plasmacytosis.
Sir.
And what else you can see, there are a lot of eosinophils.
Eosinophils.
So please pay attention to these 2 findings. If there is chronicity, if there is basal plasmacytosis present or not, and if in addition I am seeing lot of eosinophils in addition to that. Because combination of basal plasmacytosis and eosinophils are very important. So, and what else you can see in this picture?
So the neutrophils entering into the crypt lining.
Okay. So can we now modify our interpretation, morphological
So
interpretation?
there's
What we made?
activity, sir. So
So-
there is activity as well.
Yes. So we'll make it a diffuse
Diffuse.
chronic active colitis. Do you agree?
Yes, sir.
So see, the interpretation is so easy. So you have to just pay attention to all these findings. So this is diffuse chronic active colitis, and we have seen basal plasmacytosis and eosinophils. So you can see there is a crypt abscess, it is rupturing. There are many eosinophils,
Yes, sir.
and we'll go to further. So now we have seen architectural distortion and activity are not disease specific. So you need to know similar findings can be seen in IBD type of colitis and non-IBD type of colitis. So when we should think of IBD type of colitis? So these are the findings. So if you see basal plasmacytosis involving at least 3 or more anatomical regions means all these biopsy fragments, then there is a chance that the patient is having IBD. 80% chance is IBD. And if you see that the basal plasmacytosis is involving maybe 4 out of 5 fragments, then chance of ulcerative colitis is also around 80%. In Crohn's disease, you can see basal plasmacytosis, but it is not a consistent finding, or it is not a diffuse finding across all the area of the intestine. Is that clear?
Yes, sir.
And if it is a only ileocecal biopsy, you have to reserve your interpretation, because
Sure.
there you can physiologically see focal basal plasmacytosis. So what is important to tell something as in IBD or think favor IBD, I have to see crypt distortion, I have to see activity, then I have to look for the basal plasmacytosis and if there are a lot of eosinophils or not. So combination of all these, I will favor a finding of IBD. Now think, basal plasmacytosis is not important for only diagnosis, but this is the most earliest feature. And if you look at there are very few studies based on these specific histological parameters, and this is one of the most dependable histological parameter which has been described to identify basal plasmacytosis. And all of you know there are a lot of changes that leads to inflammatory bowel disease, change in the gut microbiome. There is a lot of cytokine that is secreted. Patient should have a genetic background. There are environmental factors, maybe cigarette smoker or patient is taking some immune modulators. All of them will lead to or stimulate your cytokines, Th1, Th2. And all these cause increased release of the cytokines and chemokines. And why these basal plasmacytosis and eosinophils we see especially in this zone, it has been seen that in inflammatory bowel disease, this specific receptor, that is, what is this receptor? This is an interferon receptor. Alpha 4 beta 7 receptor, this is overexpressed on the inflammatory cells, all these inflammatory cells. And what is their ligand? Their ligand is ICAM. Okay, that is an adhesion molecule that is present on fibroblast endothelial cell. And it has been seen that because of their attraction, these plasma cells and eosinophils, they are specially polarized to that zone. That's why we see basal plasmacytosis in IBD. So in case 4, what was our morphological interpretation? So I divide my interpretation into different parts. For any histological case, you have to first identify morphologically what you have seen. So this is a diffuse, chronic, active colitis with basal plasmacytosis and eosinophilia. So what I will do based on my background knowledge, I will say this is IBD type of colitis. And which type of colitis can you further classify? I have already written ulcerative colitis because all of you know it is a diffuse disease, and I have already told basal plasmacytosis is a consistent feature across most of the fragments. Okay, so based on that, and not only you have to note the findings, you have to see what terminology I am using. See, these are the recommended terminology. You should not say this is IBD NOS, or you will say this is a maybe this is a non-specific colitis. All those terminologies should not be used because it creates confusion. So if you are because in this case I didn't give you any radiological findings, so you are unsure about the clinical presentation, but your histological findings are favoring ulcerative colitis. That's why the favoring terminology should come. And if you know the clinical findings, if you know the endoscopic findings, radiological findings, and everything is matching, then you will say it is IBD type of colitis and it is diagnostic of ulcerative colitis. So you can either favor or you can say this is diagnostic or not. Okay? Please remember the terminologies. And we have discussed about the neutrophilic activity, just one slide about that. What is the importance of neutrophilic activity? We have already said it is a a marker of disease activity or acuteness, and it almost very nicely correlates with the fecal calprotectin level and the endoscopic or colonoscopic finding of erythema and ulceration. But always remember, we do follow-up biopsies also to see if the patient is responding to steroids or anti-inflammatory or biologicals. You will get follow-up biopsies in IBD also. Then you have to also score the biopsies and see if the inflammation or activity is still there or not. Please remember, during the follow-up biopsy, the histology is gold standard, because even if you see endoscopically there is no ulcer, no erythema, there can be a discordance up to 50%. So you are seeing histological activity, but endoscopically the patient is in remission. So that means you have to continue the treatment for some more time. Okay, so that's why follow-up biopsies are very much important. And as I was discussing about the grading, there are various grading systems available like Givoy score, Robert score, Nancy score. These are very validated, and where you can see both architectural distortion, eosinophil density, neutrophilic density, everything is graded. But during routine reporting, this is very cumbersome. You can do for your projects and studies, but what we follow is actually this one. This is very accepted one. So it is most important clinically how much active disease is. That means neutrophilic activity. And what we see, how many biopsy fragments and how many crypts we are seeing in that biopsy, in that slide. And we see if neutrophilic activity is involving less than 50% of the crypt area, or it is more than 50% of the crypt area. Then we say it is grade 1 or grade 2. And irrespective of the distribution, if you see either erosion or ulceration, that will be grade 3 activity. So you have to always grade. Please remember. And why grading is important? Because if you don't grade the biopsy in activity at the baseline, how you will correlate or compare during the follow-up biopsies. That's why it is important. Okay. So always grade the neutrophilic activity, and you can follow this simplified rule. And mucosal healing is important, because why it is important to get rid of the neutrophils? Because if during a follow-up you are reporting there is no neutrophilic activity, or it is a quiescent disease, we call it quiescent disease, there are chances of reduced relapse further, reduced hospitalization, the chance of colectomy is very less, and if the patient remains active disease, pancolitis for long time, chances of dysplastic change will be very high. Okay, so further complications will also be much lesser. So with that, we'll come to the next student, Dr. Kirti or Dr. Shikha, case number 5.
Yes, sir.
Sir, I had a question.
Case number
sir.
5.
Please. Yes.
Sir, is it okay to ask questions? Sir?
Yes, please.
Sir, in that the case which I had presented, the ileocecal biopsy, so in that basal plasmacytosis and eosinophils are common. So if the crypts are not distorted and the mucosa was not inflamed, can we call it as a normal biopsy, sir?
We never say it is normal. See, the patient is having some symptoms. He has turned up to the OPD, endoscopy room, and a biopsy was taken. You are not seeing distortion, that is okay. You are not seeing neutrophil, that is okay. But there is some inflammation. So it is not ideal to call it normal. What we report, it is non-diagnostic. Okay. So if you see there is a discordance, because pathology, what is pathology? Pathology, we are slave of sampling. You have to always remember. Ma'am sees so many soft tissue tumor and other tumors. So if it is not sampled, you will not see. So the area of sampling is very important. So whatever you are seeing, if it is not matching with the clinical presentation, just say it may be perilesional, or we say it is not diagnostic.
Yes, sir. Thank you, sir.
So case number 5, next
Case
student.
number 5. Yes, sir.
Yes.
So,
So
here
I
in
will
the
give my
local
lead questions,
Yes,
okay?
sir. Okay.
They are there or not? It is stuck?
Yes, sir.
No, these are the questions. You can go ahead. So
So
site of
here in
biopsy, can you comment?
Yes, sir. This is from the colonic mucosa.
No, colon is okay. Which part of the colon? I am asking for a reason.
part?
So we have seen ileocecal junction, we have seen cecal biopsies. So what you have to see?
Right side.
To guess, obviously you have to guess. You can
Both
roughly
sides.
guess if it is from the right side or left side of the colon. How? you have to compare the
So-
number of the goblet cell vis-a-vis the
Goblet
number
cells
of
will
the
be high
absorptive
in-
cells. Yes.
Yeah,
In
goblet
which
cells
part?
will be higher in the left side, sir.
Left
It will
side
be
means
little
distal
lesser.
colon. Distal colon.
Left colon.
And you can see here so many goblet cells you can see. So which
Yes,
site of biopsy you will think? Either sigmoid
Left.
colon or rectum. Left side.
Sigmoid
Okay.
colon or rectum.
Okay, go ahead, please.
Their section study
Architecture.
shows, architecture is fairly preserved, sir. It's not that
Fairly
much
preserved.
disturbed in the
You
loop.
have to see very
Crypt
carefully.
architecture.
Because we have seen in the previous case and we raise the point, the changes can be diffuse or
sir.
changes can be focal.
This is focal, sir. Here we can see also patchy inflammation is
Okay.
also there in all the fragments.
Mhm. But these are lymphoid aggregates, what you are
Lymphoid aggregates
showing
and,
us. But I will show you
Yes, sir.
some more other areas. See this area?
Yes, sir.
Compare the density of inflammation with this area. It is
Here
higher
the
here.
inflammation is higher.
Okay? Higher
Inflammation
here.
is higher.
I will show you some crypts like this crypt. What do you see? These are back-to-back arranged. These are back-to-back
branching-
arranged. This is
branching
crypt
crypts.
inside a crypt. These are features of chronicity. There are some dilated
Chronicity.
crypt. At places you are not seeing crypt. So I'm just
Loss of
trying to
crypts are
make
also
you
there.
understand, okay, slowly. So in this area it is relatively normal, though the mucosa is inflamed, it is redistributed, okay.
Yes, sir.
So what I will say, it is inflamed, architecture is focally distorted. I already gave you a leading question, it is focal or diffuse,
Yes,
obviously it is
Focally.
focal. So
Focally
if I have to interpret in this part, so I will say this is possibly a patchy chronic
Patchy.
colitis or proctitis,
Yes, sir.
whatever. Now see, there are two leading questions because you have gone to higher power. I told you in higher power what you have to see, you have to look for if the crypts are short, there is basal zone, basal plasmacytosis, type of inflammatory cell. Look at the questions.
Basal plasmacytosis.
Present or
Yes, sir.
not?
There are basal plasmacytosis is there.
Basal plasmacytosis, you think that is present. But
Yes, sir.
if I show you, so you think this is the area where maybe some basal plasmacytosis, but I will show you some other areas like this area or this area, it is not present. See the crypt,
Yes, sir.
the deepest part of the crypt is pinching on the muscularis mucosae, which is normal. So basal plasmacytosis is not a consistent
also
feature here.
normal.
And I thought these are all lymphocytes. These are not actually plasma cells. So you have to really see plasma cells. But there are some eosinophils. Okay? Eosinophils are there. You agree?
Yes, sir. Yes, sir.
Okay.
Eosinophils are there.
And we already have seen what is basal plasmacytosis and how to see if it is distributed all across the mucosal fragments or not. So, keeping those features in mind, this is patchy chronic colitis, what you have seen till now. And I thought there is not much basal plasmacytosis, though eosinophilia is there. What you can see in this picture?
So cryptapsis is there.
That is a feature of
Chronicity. Cryptapsis is there.
chronicity or activity?
Activity.
Activity.
Neutrophilic
So,
collection within the
neutrophilic collection. So neutrophil, it is activity. So now,
Activity.
what will be your morphological interpretation? So this is patchy.
Patchy.
It was chronic.
Chronic. Active.
Now it is active also. So colitis.
Yes, sir. Active also.
Okay.
Chronic
So then
active.
it is patchy chronic active colitis.
Chronic
and,
active colitis.
and there is, you also showed there is focal basal plasmacytosis and eosinophilia.
And eosinophilia.
So what do you think? It is a patchy disease, and all of you know the patchy lesions can be seen in Crohn's disease. So
Crohn's.
can you just jump and make a diagnosis of Crohn's disease in this case? Or do you consider any other differential diagnosis? I have already showed you a
Yes, sir,
list
sorry.
of differential diagnosis. The most important underlined ones you should not
TB.
forget. So tuberculosis. So I
Tuberculosis.
already told you the patchy chronic active changes can be seen in both tuberculosis as well as
Some tuberculosis.
Crohn's disease. Now see, we did some study, and these are the site of distribution between the Crohn's and tuberculosis. Most commonly you will see they are involving either in the ileocecal junction. That's why we get most of the biopsies from the ileocecal junction, and always the differential diagnosis from the clinician, is it tuberculosis or Crohn's. And also, if you look at the second most common biopsy site, that is the distal most part of the colon, that is also not uncommonly involved, but both the inflammatory cells. So if you see patchy chronic active colitis either at the ileocecal junction or in the distal colon, unless you see some other specific features, we cannot differentiate. We can say this is chronic active colitis, but we cannot, you have to commit that we cannot differentiate further, finally investigate further. Now I will show you, these are common features which you can see in both tuberculosis and Crohn's. This is a ileocecal biopsy. You can see the villi are some places short, crypts are distorted. You can see lot of inflammation. These are branching, eosinophilia. This is the cecum. You can see inflammation is more here. It is almost normal here. Like this area, it is absolutely normal. So this is patchy inflammation. In other areas, there are features of chronicity. So patchy chronic active ileocolitis-like feature. Here also you can see this part of the mucosa is almost looking normal, but these parts are inflamed. There are features of activity. Somewhere the ulcerations are going deep, like rail track, and ulcers can also go inside the muscle, and sometimes they can rupture also. But please remember, all these features can be seen both in Crohn's and tuberculosis. Like here you can see some more features. If you see the basal plasmacytosis, that will favor Crohn's over tuberculosis, but you have to see the site of the biopsy. You can see dense lymphocytic infiltrate into the deeper part of the mucosa in both the conditions, and all of you know stricture can involve in both the diseases. Okay, you can see both in both the diseases, tuberculosis as well as Crohn's. So all are common. So what are the uncommon and differentiating feature? We are talking today about the endoscopic biopsies. Obviously, you will not get a endoscopic findings like this or specimen like this. So we know that if there is a classical transverse ulcer like this or purse string ulcer, we will favor tuberculosis. Like these are the purse string ulcer. And if you see longitudinal ulcers and the mucosa is diffusely inflamed, will favor something as UC or IBD more rather than tuberculosis. But this is a very rare finding on specimens. So which feature will help us when we see granulomas? And at least some part of the submucosa is sampled. And if you see a large granuloma like this, or if you see multiple granulomas in a slide, it is said that if you see 5 or more large granulomas in a slide across the multiple biopsy fragments, chance of tuberculosis is very high. If you see the granulomas are kissing each other, that means confluence of the granulomas. That is another finding we commonly see in tuberculosis. See, these are the confluent granulomas. I have numbered them for you. You can see giant cells. Giant cells are more common in tuberculosis, but please remember, sometimes in Crohn's disease also we can see multinucleated giant cells. So only thing is granulomas, if you see large granulomas, they will help you. Number of granulomas can help you, and also the site of the granulomas. If you see the granulomas are present more in the submucosa or into the deeper part of the biopsies or specimen like in the muscle layer or in the subserosa, chance of tuberculosis is much more than the Crohn's. On the other hand, mucosal small granulomas can be seen in both Crohn's, these are Crohn's, and as well as tuberculosis. So we saw the deeper granulomas which can be large. Large granuloma can also be seen in the mucosa. But please remember, we always talk about cryptolytic or small granulomas or microgranulomas in the mucosa. We call something as microgranuloma when the size of the granuloma is either equal to a diameter of the crypt or it is smaller, like this. But please remember, in Crohn's disease, the granulomas are never well formed. It is a mere conglomeration of all the inflammatory cells, including eosinophils and histiocytes. However, in the tuberculosis, it will look like a button. Even the granulomas are small, they will pop up under the microscope. So here the biopsy or the granuloma, though it is small, it is very well formed. Okay? So well-formed granuloma, even if you are getting a mucosal biopsy, so you cannot differentiate. You can discuss with your clinician, this is a well-formed granuloma, look at the radiological picture, I think this can be tuberculosis also. On the other hand, if you see vague granuloma like this, if the granuloma is destroying the crypt or adjacent to a crypt, then we can favor it may be a Crohn's disease. Then you can take help of ancillary techniques. How to get rid of this markings?
Sir, when you move to the next slide, it will go.
I have already
No,
moved.
no, it won't. You know, you've got a. Have you got a menu on the left-hand side of your screen?
I can right click and see.
No. If you've got a menu, because somebody had annotated, right?
Yeah.
Do you have a menu on the left-hand side of your screen?
Yes, yes.
Yes. So there you will see one thing is to remove the annotation. Yeah?
There is an eraser, clear,
Yeah, just check.
clear all in. Yes, yes. Thank you.
Yes.
Thank you.
All right. So once that's what you can do. Thank you.
Yeah, thank you. So we can come back to the case number 5 again with that background. Now this picture also I gave you. So what you are seeing
Yes,
now?
sir. Here I
So
can
we
see
have seen,
the
yes,
histiocytic collection.
histiocytic collection, well formed or ill formed?
Ill-formed.
It is quite ill formed, and see it is eating on the crypts or epithelium. So that's why it is called cryptolytic granulomas or pericryptal granulomas. So it was a patchy disease. There was not
Chronic active
consistent,
colitis.
yes, chronic active colitis, patchy with a mucosal small microgranuloma. Can you favor something?
Yes, sir. Inflammatory bowel disease, probably CD over
Yes.
tuberculosis, Crohn's
So
over tuberculosis.
you cannot be 100% sure. Please remember that. So you can only favor if it is a Crohn's over tuberculosis. Okay? So your terminology should be like that. So this is your morphological diagnosis, patchy chronic active with focal plasmacytosis eosinophilia. Always write a morphological diagnosis followed by your etiological interpretation. Okay?
Yes,
If
sir.
you can do that. So with that, we'll come to the case number 6. Dr. Shikha,
Sir, one
Dr.
doubt.
Gauri. Yes, please.
So one doubt. So if we see chronic patchy active colitis on the left side, like almost normal on the right side. So if there is no granuloma, can we favor Crohn's over tuberculosis?
As I told you, though tuberculosis is lesser on the left side, but it involved the left side also. So just based on your histological finding, you cannot favor, I guess.
Okay.
Okay?
Okay, sir.
Yeah.
Thank you.
So case number 6, other student. Dr. Gauri. Or I will go ahead. So which site of biopsy this is? Intestine this is? Anybody can guess? What you can see on the surface?
Villi are there.
So
Already
villi are there. So this is
ileocecal.
Or the ileocecal.
at least ileal biopsy you can say. And anything in this low power you can see? Anything? Anybody has noticed? All of you can join the discussion. Any findings? Or if I ask you if the mucosa fragments are inflamed or if there is chronicity, anything? So let us go to the low
it is
higher
here, sir.
power, next one. So this is one picture from the ileum, one picture I have given from the cecum. So tell your morphological interpretation on both. Mucosa is inflamed or not?
Mucosa is inflamed.
Inflamed.
Yes,
If
sir.
there is features of chronicity,
Yes, sir. In the
Yes.
ileum, it looks more.
okay. And it is in the cecum, it is looking normal.
Yes, yes.
Do you think the crypts are very much short and you can see basal plasmacytosis or eosinophilia? So just notice the steps, what I am trying to tell you. So architecture ho gaya, type of inflammatory cell, if it is patchy, diffuse, you have seen. Then you have to look at the basal plasmacytosis are there or not, or eosinophils are there or not. So not much. Okay.
Yes. Okay.
So let us see this high power picture I have given. What you can see.
Well, granular.
It's a uniform granuloma state.
What is the site of the granuloma?
Submucosal.
Yes, it is just below the muscularis mucosae. Sorry. So this is this is a submucosal granuloma. I cannot see lot of basal plasmacytosis or eosinophilia. This is a ileocecal junction. So what will be in your mind? What you are seeing?
Crohn's.
Why Crohn's? I told you if you see deeper granulomas and the granulomas are so tuberculosis.
TB. Yes, sir.
Is that clear?
Yes.
Yes, sir.
Okay. This is a submucosal granuloma you can see, and this is not pericryptal small vague granulomas. So I will keep a possibility and look for more findings. So there was actually large granuloma like this, and see this is in the mucosa. So if you see a large well-formed granuloma, what will be your possibility?
TB.
You will favor tuberculosis. And please remember, this is a rule which will be true for in 95-96% cases, but I have some rare examples where there are large granulomas and we favor tuberculosis, but the patient behaved like Crohn's disease, and after they did not respond to ATT. However, later when the treatment was revised, they responded to anti-inflammatory and steroids, okay, anti-inflammatory regime and steroids. So they were actually phenotypically more like Crohn's. So, but in majority of cases, if you see a granuloma like this with giant cell, there is submucosal granuloma, large mucosal well-formed granuloma, you will favor a diagnosis of tuberculosis. So I'll come to junior, who is from second year. Another case number 7 I gave you. What you can see from the surface of the mucosa. Can you tell me one by one from the surface in the mucosa, submucosa, lower part, what all you can identify in this?
Ulcerated mucosa is seen.
Okay.
And, atrophy can be seen over there.
Okay.
Along with the loss in the crypts can also be seen.
Mm-hmm.
Then the muscular mucosa can be seen, and the submucosa has multiple granulomas.
So, what you are cooking in your mind, what it can be? There are multiple submucosal granulomas. The granulomas are large.
Yeah.
Yes.
And what else I told you? You have to also see how the granulomas are positioned. If they are next to each other or there is confluence of the granuloma. So whenever you are describe these terminologies. So large submucosal granuloma, tell the site if they are confluent or not. So if you see confluence, multiple number, what you will think?
Crohn's.
Crohn's?
Tuberculosis.
So we said if you see more number of granulomas, if you see deeper number of deeper site of granulomas, or the granulomas are confluent and they are large size granulomas, then chance of tuberculosis is high. Okay, so tuberculosis you have to think. So we are seeing all these changes, and this is the confluence of granulomas. You can see these are all granulomas. They are situated next to each other. So we call them confluent granulomas, and these are the giant cell. So when we see something like this situated into the deeper muscle layer, we favor a diagnosis of tuberculosis over Crohn's disease. Please remember that. And this is a bonus. If you find one of your granulomas are showing necrosis, along with all those findings, then obviously you will favor tuberculosis, and you will do your ancillary stains and markers, whatever you have. So this is actually a chronic active colitis with confluent microgranulomas. We always write these terminologies, descriptive terminologies in our morphological report with focal necrosis, and with that we will say, because as there was necrosis, the features are of tuberculosis. Okay, so we think definitely it is tuberculosis. That's why this type of terminologies was used. Now we'll very briefly talk about the mimickers of the IBD. So I have shown you a few scenarios. Can it be drug? Can it be persistent infection? The patient can have malignancy anywhere in the body, undergoing radiation therapy, or there are immune activated cells, maybe GVHD. So in any conditions, if you understand what is happening, if it injures the mucosa, there will be ulceration, and after that the injury is no more there. So there will be regeneration. And what are the features of regeneration? All of you know, the stem cells stay here. So there will be increased cell number. There will be what will be there? There will be branching of the crypts. The crypts will be elongated. So that is only what? That is the architectural distortion. So if you have multiple bouts of acute insult followed by a chance to regeneration or regenerate the mucosa, so what you will end up with? The morphologically you will have features of activity as well as chronicity. So chronic active colitis along with IBD and tuberculosis, you have to have all these differential diagnoses. If the patient is taking any drugs per se, NSAID, taking for long time for rheumatic disease, if there is a persistent infection, if the patient has undergone radiation therapy or not, if the patient has some background where immune activated cells are is playing a role, or if the patient is getting anti-immune therapy or immune checkpoint inhibitors like PD-L1, or if there is a ischemia, acute bout of ischemia followed by healing. So all those features will show you mucosal ulceration along with distortion. So chronic active colitis. So all will be differential diagnosis. So for example, see what you are seeing here, this is actually a chronic ischemic colitis. What you are seeing, chronic active or acute on chronic ischemic colitis, here there is ischemic necrosis of the mucosa. However, if you look at the adjacent mucosa, there are features of chronicity because the mucosa is undergoing regeneration. Here what you are seeing, this is acute ischemic insult. All the mucosa has undergone ischemic necrosis, and when we say something, the mucosa is undergoing acute ischemic change. If you look at the mucosa, surface part of the mucosa, there will be ischemic necrosis or hemorrhagic necrosis. However, the lower part of the crypt will be preserved. Why? Because all of you know what is the distal part. So blood vessels coming like this. So if I stop the supply from here, what will happen? The distal most part of the intestine will be affected first. Okay. So if there is a mild inflammation insult, the upper part of the mucosa will undergo hemorrhagic necrosis. So see, if the ischemic change is acute and chronic, then it will mimic an IBD. So radiation changes, there will be ulceration, and there will be healing followed by that when the doses are not being given. So there will be features of chronic active colitis like this. So all are differential diagnosis. Also, all of you know, whenever there is a IBD, ileostomy is done to rest the distal rectal stump. And in a second part of the surgery, what they will do, they will join the rest of the bowel with the rectal stump or the residual anal part of the bowel. Okay, so that is the usual practice. So whenever there is ileostomy has been done, also remember it is the rectum, ileum, they not only have their secretory and absorptive function, they also require nutrition from what we eat. So they are devoid of all those fatty acids which are required for their health, all the enterocytes. So whenever there is diversion, the distal rectum, what will they will face? They will face there is a bacterial stasis, bacterial overgrowth. In addition, there is no nutrition. So they will undergo inflammation. There will be ulceration. The ulcer can be chronic. The ulcer can be acute. There can be ulceration also. So this is a very common finding. Before doing the second step surgery, before joining the ileostomy with the rest of the rectal stump, before completion of second part of the surgery, they will take a biopsy and they will ask you if IBD is still there or not. If you say yes, IBD is there in the rectal stump, they will not go ahead with the surgery. But you have to then identify what is diversion colitis. Diversion colitis is what I told you. Because this colitis is being precipitated because of lack of nutrition and because of bacterial proliferation or bacterial overgrowth. So how to identify? So as a part of the chronic active colitis, you will see architectural distortion, inflammation, ulcer, all those changes will be there. But in addition, one important clue will be there, too many lymphoid aggregates into the rectal stump. So if you see too many lymphoid aggregates, that is usually a sign of diversion colitis. So this is an example of, this is a mimicker of IBD because of the chronicity activity, but we make a diagnosis depending on the lymphoid aggregates. Is that clear? Now, other differential diagnosis like this is CVID, common variable immunodeficiency. It has three type of presentation. One is sprue-like. Sprue means like what we see in celiac disease, features of enteropathy, there will be increased IL, the crypt to villus ratio will be somewhat flattened, and there will be crypt hyperplasia. So in CVID, when the patient is immunocompromised, there are no immunoglobulins which is normal and no plasma cells, the patient will have recurrent infections. So one is sprue-like presentation. Second is, here also you will see lot of lymphoid aggregates, reactive lymphoid aggregates into the proximal part of the bowel. So I have told you two important differential diagnoses of prominent lymphoid aggregates, one into the distal rectal stump, one into the proximal bowel. So if you see too many lymphoid aggregates prominent, always go into high power and see if the plasma cells are there or not. And if the plasma cells are not there, along with reactive lymphoid aggregates, always cross-check if there is mucosal inflammation or parasitic infection like giardiasis is present or not. Because that is usually always present when the patient is having CVID because of no immunoglobulin. Okay. So if everything is present, you can suggest, we suggest many a time, kindly look for immunoglobulin level, it can be CVID. And another presentation of CVID is along with too many or too much prominent neutrophilic activity, which is also known as CVID colitis. So this CVID colitis will mimic a Crohn's disease into the proximal bowel biopsies because of chronicity and because of activity. Okay? So,
Prasanjit,
yes, ma'am.
there is a question here, and I think since you've got the small bowel up, please clear about crypt-villus ratio, how to analyze. So can you please, because you have the small bowel up here.
Okay. Yes, yes. I will quickly touch that. So crypt to villus ratio, see, this is the only small bowel picture I have, so I'll take help of this. So first, you have to see if the biopsy fragment is oriented or not. So for orientation, you have to identify if muscular is mucosa, and then you have to see, like in, I have shown you test tubes in rat in the colon, so that theory you have to also apply in the small bowel. You have to see if the crypts are perpendicularly oriented, the consecutive crypts on the muscularis mucosa or not. So if you see 3 to 4 crypts in a region are perpendicular to the muscularis mucosa, you can think that this part of the mucosa is oriented. So when the mucosa is oriented, so here also we can take it as oriented because of the same rule. Now, after you have seen the part is oriented, so what you have to see what is the crypt-villus junction. Now, this the junction we call is as a shoulder. This is not a straight line. This is a line like this. So after you have imagined the shoulder, then you have to see what is the villi length like this and what is the crypt depth like this. So here the villi almost, if you see, it is 1 is to 2.5. So crypt first. So 1 is to 2.5 or so. Normally it is 1 is to 3 to 1 is to 5. In India, you will see maximum 1 is to 3. So it is like that. And also, along with crypt to villus ratio, another thing I want to highlight that you have to identify the oriented villi, and for IELs, you have to identify the upper 1/3 of the tall villi, and here only you count, this is the apex of the villi, and start counting the IELs from this and from this. Okay, so on both sides you have to count the IELs. So count IELs in 5 oriented villi or tall villi, and then average the IELs per 100 epithelial cells. So this is in short how to look at the crypt to villus ratio.
Thank you, Prasanjit. Somebody had asked the question, so I
Yeah.
thought.
Yes, thank you, ma'am. It's okay. Now, this is another mimicker I have showed you. Not many cases we see nowadays, but I want to show you. So this is the case. You can see low power. There are features of activity. This is exudate. That means there is ulceration and there is some distortion here. You can see there is crypt loss. So this is chronic active ileitis. This is actually ileal biopsy. This is the exudate, and this is the deeper part of the ulcerated part where we could identify numerous hemophagocytosis. You can see all these are histiocytes, so hemophagocytosis is very prominent. So if you see a ulcerated ileal disease like this, no granuloma with 2 prominent hemophagocytosis, this is a complication of which disease? Any students can tell that? Where we see this? This is an example of immune dysregulation, or what you see in systemic inflammatory syndrome. So this is an example of typhoid. Okay, so this is a chronic typhoid fever, which is showing you acute and chronic ileocolitis like features, and with very prominent hemophagocytosis. So just to come back to our original discussion, this is, so any chronic persistent inflammation can be a differential diagnosis of IBD. And these are not my pictures. This is a cord colitis. So sometime when the cord blood is given for treatment, you can see this type of mucosal ulcer. There can be activity, there can be distortion. Similarly, along with cord, you can remember of any drug, especially mycophenolate or NSAIDs or immune checkpoint inhibitors like PD-L1 therapy. You will end up many more biopsies like this. So after therapy, there will be intestinal injury, there will be a lot of apoptosis, increased inflammatory cell infiltrate, and there will be chronicity also. So, but most importantly, you have to look at the form as well as you have to look at the biopsies. So again, to tell you, none of these biopsies which are not IBD related, they will show you too many eosinophils, or they will show you prominent basal plasmacytosis. So these two are very important findings, and then you will suspect if it is a IBD type colitis or non-IBD type colitis, as we have seen the differential diagnosis. So this is the last case I gave. So any student and volunteer. And I will tell you the history. This patient was known case of Crohn's disease under follow-up, and this biopsy was taken, I think, on 11th year or so after the follow-up. So what you are saying? Anyone?
So,
Yes, please.
So the sections show fragmented tissue bits, majorly lined by colonic mucosa, and the epithelial cells lining the crypt show mucodepletion. And there's a little crowding of the glands that is seen, and a few of them are cystically dilated.
Okay.
The enterocytes at higher power, they show a bit of cytological atypia in the form of mild nucleomegaly and nuclear stratification.
Like this?
Yes, sir.
So what you see in the background and what you are trying to tell us in the higher part. So what is happening?
So there's low-grade dysplasia that's setting.
Okay, you suspect it to be low-grade dysplasia. And what is the background findings?
So there is increase in the mucosal.
Stick to our basic questions. If the architecture is distorted, if the
architecture is yes, sir. So the crypt architecture is distorted, and lamina propria shows increased inflammatory cells.
So that means it is chronic colitis or ileitis, whatever, based on the site. You can tell that. And then you are saying in the background there is possibly some low-grade dysplasia. Yes, you are correct. So this is actually evidence of focal low-grade dysplasia, IBD associated in a known case of Crohn's disease. Okay, and all of you know how the surveillance is being done based on the risk factors. It is either done every yearly, or it is done every 3 yearly or 5 yearly. So if you have high risk features means if the patient has pancolitis. Pancolitis means when the inflammation starts from the rectum and crosses the splenic flexure. It is not needed that you have colonic inflammation till the cecum. So anything which crosses the splenic flexure, that is pancolitis. And if you have severe active colitis from the start on, and multiple repeated biopsies also showing on the severity or activity is persisting, and if you have other complications like PSC, those are very high risk. So every year there will be colonoscopy and follow-up biopsies will be taken. And the dysplastic lesions can be polypoidal, it can be flat. So polypoidal lesions are easily visible on the endoscope, and usually whenever they see, they can do chromoendoscopy, they can spray the methylene blue, and without histological confirmation also, they go for colonoscopic resection. But whenever the dysplasia is flat, in a follow-up biopsies, that is your domain. You have to see. So the most important message I want to give, whenever you are looking at any follow-up biopsies, along with our basic questions like architecture, type of inflammatory cell, basal plasmacytosis. So you have to also see if there are complicating factors or not. What can complicate a course of IBD if there is a superadded inflammation like CMV inflammation. So if there is a CMV infection, the patient can present with acute severe ulcerative colitis. I did not touch all those features because the time was short. That is also called necrotizing colitis. Okay. So that can be a complication. So always comment on CMV inclusions are there or not. And second most important thing, as it is a complication of chronic follow-up, that is dysplasia is there or not. Okay, you have to comment. And if the dysplasia is flat, always remember you have to take an expert opinion of your senior. Two pathologists should confirm it is dysplasia, and then you have to grade it if it is a indefinite for dysplasia, low grade or high grade dysplasia. And I guess you understand indefinite for dysplasia. So any dysplastic like lesion, like I will go back to this picture, this is very clear low grade dysplasia. But if I see the mucosa adjacent to, or the surface mucosa is ulcerated here, and I see too many neutrophilic infiltration here, then I cannot differentiate or decide if it is reactive change due to the inflammation or activity, or it is a true low-grade dysplasia. Okay. In that case, he will say this is indefinite for dysplasia, and those patients also undergo close follow-up. Okay. And if the dysplasia is flat, then there is no other chance to endoscopically resect. They have to undergo total proctocolectomy if the dysplasia is high grade. That's why you have to say it is low grade or high grade dysplasia. Now, one most important thing, I don't want to go into the type of dysplasia, but always remember in a patient with chronic IBD, the dysplasia or what is dysplasia? WHO says anything dysplastic that is an adenoma, isn't it? So we can call it adenoma. So the adenomas can be either sporadic, patient has IBD, but the uninvolved part of the colon can develop adenoma, that is a sporadic adenoma if the patient is 50-60 years old. So that is called sporadic adenoma. Or it can be IBD associated dysplasia, like there is dysplastic change and the dysplastic change has developed in as a complication of IBD. So how to differentiate that? There is two important features you have to see. If you look at these two patterns, in sporadic adenoma, we always see dysplastic change which is usually seen more towards the surface, like a tree. It is a top heavy pattern, okay? And if you look at the stalk or the lower part of the crypts or the distal crypts, they usually don't show dysplastic change. On the other hand, IBD associated dysplasia, they are usually show you bottom up pattern. Usually you will see the dysplastic change which are seen more towards the deeper inflamed glands, okay? And another thing is, if you look at the sporadic adenomas, the glands, they show either normal pattern or they will be crowded and there will be Chinese letter pattern. So there will be very less space in between. And in IBD associated dysplasia, the dysplastic glands also maintain the architecture of the IBD. Like there will be dilatation, there will be there can be branching in between stroma, that can be edematous, there can be too much inflammation. So what I mean that typical back-to-back arrangement is not commonly seen in IBD associated dysplasia. So you have to also comment what you think. If the dysplasia is sporadic or it is IBD associated dysplasia, the management will depend on that. So with those cases, so what we have seen, so what a good report should have as a description as well as interpretation. So first thing what we said, you have to look at the pattern, isn't it? Second, you have to look for the type of inflammatory cells and activity is there or not. Pattern means, I mean architecture, okay? Then you have to see neutrophilic activity is there or not. Third, you have to see if basal plasmacytosis and eosinophilia are there or not. Fourth, you have to interpret. Like morphological interpretation, we have said it is chronic active colitis or so. And then you have to classify if it is IBD type, non-IBD type, based on other associated findings. And then look for complications. If you remember my message, viral inclusion and dysplasia, please comment always. So what I did not mention, please look at the points. I have mentioned everything what we discussed today. So what I left, anything can supplement that point? Look at the points. So there is nothing to write. So what you are seeing, pattern, activity, basal plasmacytosis, eosinophilia, interpretation, classification, and complications. We discussed today. So what is left? I always told you, another important role of pathologists, anatomic pathologists is you have to grade the activity. Okay? So please remember everything. And based on this, there was a name given, PAI, and this is the complication, dysplasia. This is called the PAID system of reporting. So in your description, you have to give a description like this, and I call it BPAID. Okay? Why? Because if you are getting, or the clinical question is if it is IBD or non-IBD, you have to pay attention to basal plasmacytosis and eosinophilia. So it is my terminology, BPAID, you have to remember. Along with that, these two findings you have to remember. So I think we have discussed enough and I don't have to go through the take-home message. Most important message is stick to the approach. Look for the important features in low power as well as high power, and being a pathologist, try to give a morphological diagnosis followed by etiological diagnosis, because unless you are interpreting and doing all those exercises, how you are helping your clinical colleagues. And secondly, most important is terminology.